So we're very pleased to have Dr. Stephen Scheinman here. He's going to give a very, I would say, first-person account in a lot of ways about Dent disease and Oliver Wrong, and I think it'll be very exciting. So take it away.
Thanks very much, John. And first of all, I want to acknowledge two people who are not part of the consortium who are on the Zoom call, and honored that they are. One is Anthony Norden, who was Oliver Wrong's colleague for for all of the work that he did on Dent's disease and much else. Anthony was responsible for the measurements, for pioneering the measurements of low molecular weight proteins in proximal tubular disorder, and was a very close collaborator with Oliver. And Michaela Wrong, who is Oliver Wrong's daughter, who is an internationally renowned journalist and author, foreign correspondent for the Financial Times, and someone of whom I know from direct information Oliver was very proud of. So I'm really pleased that they're here with us. You all know all about Dent's disease and know about Oliver Wrong's contributions to Dent disease, but I'm not sure that I can assume that you are familiar with his many other contributions to nephrology. Of the 135 papers that he published during his lifetime, only about a dozen were on Dent disease. And his contributions are far-ranging and reflect, I think, the impressive nature of his intellect, his curiosity, his relationship to his patients, and his character. Oliver Wrong was born in 1925 at Magdalen College, Oxford, which is an institution with which his family had a long relationship, and he spent much of his childhood living there. He died in 2012 at the age of 87 at University College Hospital, London, where he had spent many of the productive years of his career. Magdalen College is, and some of you who've been to Oxford may recognize where he's standing in this picture. He's standing right near the Radcliffe camera. Magdalen College is a beautiful, huge part of Oxford. It is ancient, and it is associated with many Nobel Prize winners in medicine. Those include Sir Howard Florey, the discoverer of penicillin, Sir Peter Medawar for his work on immune tolerance and transplantation, and a person that some of you may know personally, Sir Peter Radcliffe, who just a few years ago won the Nobel for his work on cellular oxygen sensing. Oliver himself grew up on the grounds of Magdalen, which overlooks this huge and beautiful deer park, and past which one of the two great rivers of Oxford, the Char, passes with its punters. And his death at University College Hospital the hospital was a much larger institution than it was when he first started working there. So there is a wholeness to his life, I think, represented by his pedigree. Oliver Wrong descended from a distinguished intellectual family that included, among many other accomplished relatives, two Nobel Prize winners in his family. One is Dorothy Hodgkin, structural biologist who won the Nobel in 1964 for her work on X-ray crystallography and the structures of cholesterol, penicillin, vitamin B12, and later insulin. And Alan Hodgkin, the physiologist and biophysicist who won the Nobel in 1963 for his work on giant squid axons that led to the elucidation of the mechanism of the action potential. So these are some pretty important fundamental discoveries in his family. This is the wedding photo of Oliver Wrong's parents. Both his parents, obviously standing in the center, both of them were historians. His father, Murray Wrong, was Canadian. He taught modern history at Magdalen and in fact, was vice president of Magdalen College. His mother, Rosalind Grace Smith, also taught history at Oxford, was a member of a very prominent academic family herself. Her father, A.L. Smith, who was the master of Balliol College at Oxford. They were married in 1915, and so you can see the World War I era garb. Um, uh, Murray's father, so Oliver Wrong's father was Murray on the right, and his father, George Wrong, was himself a distinguished historian. He was from a very prominent Canadian family that included Edward Blake, the Premier of Ontario, who was Murray's maternal grandfather, so Oliver's great grandfather, um, and a family friend of the Wrong family in Toronto was Sir William Osler, who would vacation with them. And when Murray Wrong first moved from Canada to Oxford to be an undergraduate, he lived with the Oslers until he found other digs. Um, so they were close. He was also Murray Wrong's, Osler was Murray Wrong's physician. And Murray Wrong, in fact, suffered from rheumatic heart disease and died at the age of 38. At that time, that he left 6 children to his widow, and the family, the children were split up. 3 of them were sent to Canada to live with their grandfather and his family. So Oliver, from the age of 6 to the age of 13, lived in Canada with George Wrong, the distinguished historian. Came back to England at the age of 13 for school, and then went on to study at Magdalen College, where he got his medical degree and clinical training at the Radcliffe Infirmary in Oxford. And then in 1948, he did his military service in the Royal Army Medical Corps in Singapore and Malaysia, which was an experience that informed one of the most significant threads of his research interests. He then did a residency at Toronto General Hospital and a research fellowship with um, Fuller Albright and Alex Leaf at the Mass General, which is where he really developed his lifelong interest in salt and water metabolism. His first academic faculty position in 1954 was at the Manchester Royal Infirmary, and 3 years later he moved to the University College Hospital. He shortly thereafter became senior lecturer in nephrology at the Royal Postgraduate Medical School at the Hammersmith Hospital. And in 1969, had a brief experience, a 3-year experience as a department chair. He became chair of medicine at the Dundee Hospital in Scotland. And 3 years was more than enough time to convince Professor Wrong that his love was not academic administration, but rather was patience and research. And so he came back in 1972 when the opportunity was presented to him to succeed his colleague Charles Dent as professor of medicine at the Royal Postgraduate Medical School at the Hammersmith. And so that's where he remained for the remainder of his active career. I put that in quotes because he is officially retired in 1990, 22 years before he died. But he spent his time in retirement working basically without remuneration at the University College Hospital, where he had spent so many of his productive years. And in retirement, he was in many ways more productive than he had even been during his working years. So I'm going to talk about several themes of his work, starting with one of his most significant contributions, which was at the very beginning of his career, his monumental work on the excretion of acid in renal disease. It was published in the Quarterly Journal of Medicine in 1959. It's really a seminal paper because it defined the short acid load, which we still use today as the classic test for urinary acidification. And not only did he provide what Robert Owen has called a detailed and descriptive tour de force of acid handling by the kidney using this test, but he defined the criterion for renal tubular acidosis that we still use today, which is a urinary pH of 5.3, inability to acidify below that. Um, he This was a 54-page article, and he wrote, excretion of acid is impaired in renal disease, and acidosis frequently results, but there is little information as to how the chief variables of acid excretion are affected in different forms of renal disease. And he answered that pretty definitively in this first paper. First of all, he defined the normal ranges for urinary pH, ammonium excretion, and titratable acid excretion across the range of urinary pHs. And so we see on the left here the normal ranges that this study defines, and the well-established observation that we're all familiar with, that ammonium excretion increases as the urine becomes more acid. In chronic renal failure, he taught us that the problem is not the ability to acidify the urine. The nephrons that remain in chronic renal failure may become fewer and fewer, but each one is still able to achieve a low urinary pH. The problem is that the kidneys have lost sufficient mass that they cannot excrete a sufficient amount of buffer. And so ammonium excretion impairment is the major reason for acidosis in chronic renal failure, as contrasted with renal tubular acidosis. And in fact, the data in this paper gave us the information that we need to define what we now know. These terms weren't used in the 50s as distal renal tubular acidosis or classic renal tubular acidosis. All of his patients in this study met those criteria, and as we see here, none of them were able to acidify below a pH of 5.3. This paper is where that criterion comes from, but they are still able to excrete ammonium in adequate amounts because renal mass is nephron number is not impaired, and so this explained to Oliver. It's another insight that emerges for the first time from this paper, why some people can have an impaired ability to acidify their urine and not develop systemic acidosis. It's because they do have the ability to raise their ammonium excretion. So seminal paper. Another interest, one might even say the word interest is not quite strong enough, is his interest in the role of the intestine in acid-base metabolism and electrolyte metabolism. And so he wrote this paper in 1965 when he was back in London on the electrolyte content of feces. And he was disappointed in the medical establishment at large that they had a distaste for handling feces and would not study it. And so he wrote famously, "Stool is the Cinderella of electrolyte studies. It's a fascinating material. It contains 70% or more water. It's also known to contain many electrolytes, which are usually identified after ashing in a muffled furnace, a procedure which destroys all organic material and tells us nothing about the physical state of the inorganic constituents." And so in this study, in this and subsequent studies, Oliver used a technique that he perfected over the course of 5,000 of these cellulose tubes. So in the middle of this slide, well, on the right-hand side, you see a clear cellulose tube that could be rolled up, put into a capsule, and swallowed. And he was apparently relentless in getting his colleagues and his friends and his family to swallow these capsules, although nobody swallowed as many capsules as Oliver himself did. In fact, Michaela, his daughter, who is on this call, and she can correct me on this or anything else, she and Anthony are my conscience in this talk, will say that she grew up with the impression that this was what normal families did at breakfast. You swallow a capsule, and then when it emerges later in the day, it is sent off for study. So with all of this exertion, what was learned? Well, actually quite a bit. First of all, he defined the normal range for electrolyte composition of the final stool. And here you just have a table, I'm not going to go through it, of the normal electrolyte composition. And with that, you can study abnormal circumstances. So for example, primary aldosteronism. Here's a patient, pre and post resection of a tumor with primary aldosteronism. So pre-op, this patient has excessive urinary potassium and very low urinary sodium, consistent with, obviously, a vanishingly low sodium potassium ratio, consistent with the known effects of aldosterone. And then post-operatively, you can see that these numbers correct to the normal range. The sodium potassium ratio is completely normal. So confirming the role of aldosterone in colonic electrolyte transport. Another study using this method looked at the effect of lactulose on fecal pH and ammonia concentration, and the normal level, which he had defined in a previous study, is shown by the dashed line. And you can see when people take lactulose, two things happen. One is that their ammonium excretion in the stool is lower than normal. And the second is that the relationship between pH and stool ammonia disappears, overwhelmed by the osmotic effect of the lactulose. And so insights like this are made possible by Oliver's scientific approach to studying stool electrolytes. And then in 1990, and I'm obviously breezing through this because time is limited, in 1990, he retires. He retired by moving, he and his wife moved to central London so that he could walk to the Middlesex Hospital and to the libraries in central London, and spend more time on his work. And so we're all familiar with his work on Dent disease. And he did us the great service of naming this disease after Charles Dent. Now, I think we all recognize that Charles Dent's original 1964 description did not include that these patients had a family history. In fact, Charles Dent believed himself that this was nephrotoxicity and not familial. He didn't recognize a family history. He didn't follow them long enough to determine whether they developed renal failure, and kidney stones were not part of his description. So I think most people would not have named this disease for Charles Dent. I think it would have been much more appropriate to name this disease for Oliver Wrong, whose paper, when it did come out 30 years later, he's retired and he finally can put everything together, and has been following the Charles Dent's patients and other patients for 30 years and more. When that paper finally came out in the Quarterly Journal of Medicine, and as is typical of Oliver's papers and Quarterly Journal papers in general, it was very thorough. And the title of the disease provides a full phenotypic description of Dent disease: a familial proximal renal tubular syndrome with low molecular proteinuria, hypercalciuria, nephrocalcinosis, metabolic bone disease, progressive renal failure, and a marked male predominance. So there are a couple of reasons why he wanted to call it Dent disease. Anthony Norden has said that it's not correct to call Charles Dent his mentor. They were colleagues, they worked together. He succeeded him in the professorship, but I think that Oliver did want to honor him, A. B, it's a nice pithy name, Dent disease. And C, he was self-effacing and concerned that if it became named for wrong, if it was wrong disease, you can imagine the jokes on the wards. And he was conscious of this. And so he selflessly encouraged everybody to call it Dent disease, which is what we call it today, although at the very least, we might call it Dent wrong disease. And there have been some papers with that title. And so Charles Dent's two patients, we now know the first one had mutation in CLC5, but the second one did not. And when that puzzle bothered Oliver, and he was convinced there was another gene. And every time we would talk about it, he would point out that this child was, in his phrase, mentally backward, had an IQ of 65. I'm sure, Oliver would say, I'm sure that's a clue to what is going on. And in fact, we now know that that case number 2 had mutation in OCRL1, which of course he's lucky he's only mentally backward and not much more severely um, uh, compromised. And so one important reason why Oliver was so good at collecting specimens and collecting data and collecting family histories from his patients is that he had a deep and strong relationship with them. They could call him at any hour of the day or night. He could ask them anything, and he'd say, "Could you do a 24-hour urine, and I'll swing by in 2 days and collect it?" And he would drive throughout southern England doing this. And so here I am with him on one of those trips, but Anthony on the phone accompanied him on many more of those trips. So this picture, Oliver is the second from the left, the most distinguished of the people in the picture, standing with Anthony Norden and Terry Feast, his 2 co-authors on that 1994 description of Dent disease. Thomas Jentzsch in the middle, who described the CLC family of chloride transporters, and Raj Thacker, who has made so many contributions to our molecular understanding of Dent disease. Then there's this interloper here. His other deep interest in retirement, and really his first publications on this didn't come out until 7 or 8 years into retirement, were on the band 3 anion exchanger and Southeast Asian ovalocytosis. Now remember that he had spent his military service in Southeast Asia. And the band 3 protein is the most abundant of the proteins in the red cell membrane. It is a structural protein in the red cell membrane, and is important in connecting the cell membrane with the cytoskeleton. And it was well known that mutations in the band 3 protein were responsible for what was first called elliptocytosis and is now called ovalocytosis in Southeast Asia, and well recognized to be endemic in Southeast Asia because, like the thalassemias and sickle cell disease, it conveys a resistance to the falciparum, a malaria parasite. But Oliver, with his colleagues in this paper from 1997, were the first to demonstrate that a mutation in that gene is responsible for distal renal tubular acidosis. This was in patients in England. They were not from Southeast Asia. They did not have ovalocytosis, but it was the same gene. And so pursuing that gene, they subsequently demonstrated that a recessive form of renal tubular acidosis occurred in Southeast Asia in patients with ovalocytosis. So he wrote, with colleagues, he wrote a number of patients on this over the last 15 years of his life. The cells, you can see the typical ovalocytes of the disease. He defined specific mutations and the geography of those mutations. And so the band 3 protein is the chloride bicarbonate anion exchanger that exists on the basolateral surface of the alpha intercalated cells of the collecting duct, so that the bicarbonate produced by the activity of carbonic anhydrase can be excreted from the cells. Impairment here will obviously impair the ability of carbonic anhydrase to continue generating acid to be secreted. This is from Oliver's, this diagram is from Oliver's paper. His work, this published in 2002, defined the association between those specific mutations in this gene and their geographic location throughout Southeast Asia. And then 10 years later, in a paper in the Quarterly Journal of Medicine, appropriately, when he expanded significantly on this, you can see that the experience has broadened geographically across Southeast Asia. This paper, from which that map comes, was his last paper. And he was working on that paper on his deathbed at University College Hospital in the ICU. When I say that when I call this a life well lived, I think it's hard to argue with his scientific accomplishments. But I think absolutely critical to his ability to be as successful as he was his very happy marriage. This was a marriage between two people who could not have been more unlike each other. And yet, among marriages of unlike people, this was the most perfect union that I have ever witnessed. The story of how they met is legendary in the family. Several, I think there were three British soldiers on holiday in the Black Forest of southern Germany, are cruising along in a car, and they see these two pretty young ladies hitchhiking. So the guys say, Oliver's driving and wants to stop, and his colleagues say, no, we don't have any room in this car. Where are we going to put them? And Marilda is hitchhiking, and her friend says, no, we can't get in a car. It's three guys. We don't know who they are. It's not safe. But Oliver and Marilda had their way. How they both ended up, she was Italian, he was English. They both happened to be in the Black Forest. She happens to be hitchhiking at the right moment. And they both insisted on making this hitchhiking happen. And 2 years later, they're married. Here, outside the registrar's office in Italy. Marilda Masaccio was a school teacher and was vivacious, brilliant, and outgoing, and the exact opposite of Oliver. You think that Englishmen are typically reserved. He was more reserved than that, and he had, according by his family's own description, difficulty expressing emotion. But they were a perfect pair. He was an accomplished pianist. He loved Bach, and he was a passionate gardener. She was very passionate about art. She was a docent at the Wallace Collection, which they could walk to, having moved into central London. And it was delightful to be in their presence when Marilda would correct Oliver in the most cheerful and funny way, and he would just acknowledge that she was right. To quote their daughter, theirs was a passionate, utterly loyal union. And just to give you an idea of her, because she was really impish. Here we are at this meeting, Oliver standing beside her, and everybody says, Marilda, come join the photo. So there she is. And I think you can see that gleam in her eye. Here they are on holiday. It was a perfect union. And so I'll end with two quotes from one of the obituaries, one of the many obituaries when Oliver died. He was a clinical scientist of broad intellectual scope whose accomplishments reflected his great energy, devotion to his patients, talent for close observation, and deep understanding of electrolyte, mineral, and acid-base physiology. Professor Rong left an indelible stamp on generations of physicians in and beyond nephrology. He was a physician whose connection with patients was deep and mutual, and an insatiably inquisitive investigator who blended close observation with the broad view. So thank you very much.
Okay, so thank you very much. And yes, the tubes, the plastic tubing was very important. I remember watching my dad. He used to wash them down with beer, very methodically. And the other thing that my dad went in for The other thing my dad went in for when we were growing up is he would stop the car. We would often be driving through Scotland in that stint where we were in Scotland, and he would stop the car and then go out into a field to pick up a cow pat. Because obviously they were fascinating, and he had to pick up the cow pat and put it in the back of the car so he could go and study it later. So that was the kind of house I grew up in. Yeah, the other nice story which I remember him talking about is when he went to Papua New Guinea in the latter part of his career. He went there with my mum, and it was all part of the studies towards the end that he was doing on renal tubular acidosis. And they knew they wanted to bring blood back, but they hadn't got the permission to do it. And my dad tended to cut corners, which is why he used families and colleagues so often as his trials. So they put the blood samples in a thermos, and just kept asking the hostesses, the stewardesses on the flight back from Papua New Guinea to just bring them ice. And I think they thought that they were drinking a lot of gin and tonics, but in fact it was to keep the thermos of blood samples cold. And then when they landed, I think it was Raj Thakur who met them at the at the airport and took the blood samples away. So all of that, I'm sure, broke every every rule in the book, no doubt. I'm sure all sorts of international laws were broken, but it got it done. So thank you. That's a really lovely tribute. He was on his deathbed, dictating to me final changes to his paper, his last paper. And I did think it was a good distraction for him, actually, because I think he knew he was dying, and he knew he was dying in his old hospital. And several colleagues, Ben Walsh and various other colleagues that he very much loved, came and said goodbye to him, and also took instructions on the last changes to that paper, which was all he wanted to do. He wanted to get that last paper done. And after he died, I'm a journalist, and getting into print is an important part of my career. But I was mortified because he had more papers published after his death than I did that year. And I thought, right, thanks, Dad, showing me up again. So thank you very much. It's lovely to see Jennifer on this call, because I think, what she's been doing with the foundation is something that my dad would have so appreciated. And he'd been fascinated by it, and he'd have wanted to get involved. And it's just such a shame that he's not around to do that. But your tribute has been beautiful. He would have loved to hear it. You've been so generous with your recognition and your praise. And it's lovely also to see Anthony on this call, because, I know they were sort of fellow conspirators and they were always talking about work right to the end. So thank you very much for including me in this. I really appreciate it.
Thank you, Michael. And for those who may not know, what Michaela was referring to with Jennifer Dent Disease Foundation, and the foundation has established a research award which is named in Oliver's honor and has been given out twice now, and so it will be longstanding. Thanks.
Thank you. That's excellent.